So we've completed the first part of our patient assessment, which was to go through the questions on our assessment or questionnaire. The second piece of that assessment is actually to get some clinical or diagnostic data from Jenna. Now, one of the most important pieces of information we're going to get, and it doesn't matter how the assessment questions were answered, whether they were all no's or all yeses or a combination, is we're going to look at range of motion. So we're going to actually have Jenna just open her mouth for us. We're going to measure range of motion, and that data is an important piece of information that will help us understand low, moderate, or high risk of developing jams. Once we have that information, we may also want to gather more diagnostic information around Jenna's joints, muscles, and her occlusion or her function, the tops of her teeth. And we're going to do both pieces of that assessment, and we'll actually talk through, as we're doing that, what we're doing, how we're gathering that data, and what I'm looking for. So Jenna, one of the first things we're going to do is we're going to just take a measurement of how wide you can open your mouth comfortably. So we're actually going to use this little disposable guide so I can get those measurements. Now, there are more than one way to measure this information. You can use disposable range of motion guides. They actually make range of motion guides that are reusable. You autoclave or sterilize them. They even make dental mirrors where the handle is marked with the distances so that you can just have your regular mirrors in your dental kit and you can measure. Or an even simpler way to do it is we do what we call the 3-finger test, and we simply ask the patient to open and see if we can measure with 3 fingers. So we're going to do that and use a disposable range of motion guide. So Jenna, the very first thing that I'd like you to do for me is just bite your teeth together. And what I'm doing is I'm looking at her overbite. So in Jenna's case, she has 0 overbite. Her teeth actually touch end to end in the anterior. If she did have overbite, I would actually use my fingernail to mark that. And then I would ask Jenna to open a little bit for me. So go ahead and open your jaw. And I would then measure how many millimeters of tooth structure she had above where I'm holding my fingernail. So we're going to add the person's overbite to how much they can open. So in Jenna's case, it's 0 because she's end to end. All right, Jenna, so what I'm going to ask you to do now for me is just open your jaw comfortably. So go as far as you can comfortably, and then I'm going to measure. So how am I going to do this? There's actually, on this device, there's a little notch that I can put over her lower incisors, and then I can read the numeric scale, and in Jenna's case, her comfortable opening is only about 19, and she didn't have any overbite, so I'm not going to add anything to that. So her total comfortable opening is 19. If she had some overbite, let's say she had 3 millimeters of overbite, I would have added 19 to 3 and come up with 22 millimeters, just so you can see how that works for a patient who has overbite. The other way that we could do this is what we call the 3-finger test. So if you don't have any way to actually measure, I would simply say to Jenna, open as far as you can comfortably, and I would go, can I actually get 3 fingers in between her upper and lower teeth? And in Jenna's case, obviously, I can't get my 3 fingers lined up like this in between her teeth. Thank you. So when we think of range of motion, we're actually going to look at how those numbers fall in one of 3 categories. So if that number is less than 40 millimeters, I need to assess that because that patient is no longer going to be in my low risk category. So something less than 40 millimeters, the patient has risk of developing jams. The other end of the spectrum is also true. If the patient was able to open more than 60 millimeters, that's telling me that the patient is at higher risk for assessing. So in Jenna's case, we already knew from her assessment that she was not in that low risk category, and now we have her diagnostic information that her opening is less than 40 millimeters comfortably, so that also says she's not in a low risk. What happens if Jenna had said no to all of the things on her questionnaire or her assessment? So she didn't have any history of any problems, but she still could open less than 40 millimeters. I already know that that's going to put her into a different risk category, that I need to get some more information now about the procedure that I'm doing. So we're going to combine what we learned from that questionnaire with our range of motion, and we're going to have that combined with data from the actual procedure we expect to do, and that's going to help us now identify which one of our 3 risk categories, low, moderate, or high, this patient and procedure together fall into, so we can proceed accordingly. So when we have a patient where we've assessed that there are some risk factors to them developing jams, or at a post-operative where they've already have some symptoms, we want to move into gathering some more information about their joints, muscles, and about their occlusion or function. So what kind of information am I going to be looking for? I want to know something about joint sounds. So often patients will tell us they have a joint sound. So with Jenna, she told me that she's had some clicking on the one side for a couple of years, but it's just as common when you ask a patient if their joints make any noise for them to say no. So we want to actually look for whether we can detect any joint sounds. I also want to see if there's any evidence of any inflammation in the joint space, and we're going to do that by doing some joint palpations. When it comes to a muscle assessment, we've already done part number 1, which is actually a critical piece of every assessment, which is gathering range of motion data. How far can the patient open comfortably? And then I can build on that and add to that by doing a muscle palpation. So does the patient have tender spots when I actually look at muscles like masseter, anterior temporalis, medial pterygoid? And then I can add to that the data about what's happening on the tops of their tooth. So I look for evidence that they actually parafunction. So I'm going to look for wear from attrition. I'm going to look for cracked teeth, fractured teeth. I can look for different indicators on their teeth like non-carious cervical lesions, Fremitus. So those are things that we all do as an extension to our traditional dentition exam. That's now going to give us much more information when we already know there's a risk factor, or we're working with a patient at a post-operative evaluation because they've already started to experience symptoms. So Jenna, what we want to do next is we're actually going to try to get some data about your joints and your muscles, and I'm actually going to look at your teeth. So to start off with, I'm actually going to do a good part of this exam, and my hands are going to be on the outside of your face, not inside your mouth, okay? And the first thing I'm going to do is I'm actually just going to put my hands right here in front of your ears, and I'm actually just going to have you open and close for me. So go ahead and open as wide as you can comfortably, and close and open and close. And there's that little click that you were telling me about, okay?
Yes.
So when Jenna opens and closes her mouth, I can feel underneath my fingers on this left-hand side a little, what we would call a click or a pop. I'm going to have you do that one more time for me. All right, and I'm not feeling anything under the left-hand side. So I already know now that I can feel what we call a palpable click or pop, and that's consistent with Jenna's report of that. So the next thing I'm going to do, Jenna, is I'm actually just going to press in this area around your jaw joint, and I'm going to do that pretty gently because I know you told me it's already a little uncomfortable, but I want you to just try, if you can, to differentiate for me between just feeling the pressure when I do that versus if you feel anything that you would call mild tenderness, of course, all the way up to something actually being painful, okay? So I'm actually going to just put my fingers right here, and I'm just going to press a little bit and let go. And I want you to tell me whether or not that was just pressure.
Just pressure.
So it was just pressure on both sides. Okay. So now I'm actually going to have you open as wide as you can comfortably. Don't force open, but just open as wide as you can comfortably. And I'm going to do the same thing right here. And I want you to tell me what you felt.
Just pressure.
So just pressure, okay? So that's looking at what we call a lateral pole palpation as well as the retrodiscal tissue palpation. And for Jenna, she said they were both just pressure. So that to me tells me I'm not really seeing evidence of a lot of joint inflammation or inflammation in the joint space. All right, so we're going to now move to your muscles, okay? So I'm actually going to put my fingers right here on your face, and I'm going to actually have you clench your teeth together for me. And I have her clench so I can find the anterior border of her masseter. All right, and I'm going to have you just relax your teeth a little bit, okay? And I'm actually just going to move my fingers across this muscle, and you tell me if any of that is tender. So is that tender right there under my finger?
Not too bad, no.
Okay, so not too bad would be more than just pressure.
Slightly.
Okay, so I'm gonna have you give me that information, and we're gonna divide it up in numbers, and we're gonna use 0 to 5. So if 0 was just pressure, and 5 was something really uncomfortable or painful, what would you give me as a number for that? A 1, okay? So I stopped there because I actually felt a little, what we call a taut band, or a little place where the muscle didn't feel real soft and smooth. And I typically know those are places I'm more likely to have a patient tell me that it's tender, okay? And that was on the right-hand side. Okay. And any place else in this muscle that feels a little tender?
Over here.
Right there? Okay, so same thing. Give me a number for that.
A 1.
A 1? Okay. And then when you were doing it before, you were showing me that it was tender up there. So is that tender for you?
No.
No? How about right here? Right there? Okay. Both sides? Okay. And then give me a number for that.
2.
Okay. So we're going to look at the whole masseter muscle. We typically want to look at both its origin and insertion and the body of the muscle. And of course, I could always ask Jenna, since she told us in her assessment that she had some places that were sore, and have her actually find those on her own face and show me if I'm not isolating those same spots. We're going to do the same thing with her anterior temporalis muscle. So Jenna, I'm going to have you clench your teeth together again for me. And I do that to feel where the muscle is popping. Go ahead and relax. And then I'm just going to press or palpate in this muscle and have you tell me if any of these are sore or tender.
Maybe a 1 on the left.
On the left-hand side, just right in there?
Mm-hmm.
Okay. And anything at all on this right-hand side? No?
Nope.
Okay. Any other spots on this left-hand side?
Nope.
No? Okay. Any place that you know it's sore that I didn't touch that you could show me?
No.
No? Okay. So we've done her masseter and her anterior temporalis. When I do joint palpation, I'm usually trying to do about 1 to 2 pounds of pressure. How do I know that? If I didn't have gloves on, you could do this yourself. You could just press your thumb and your forefinger together. And as soon as your nail bed blanches on your thumb, you're about 1 pound of pressure. Typically when I do muscle palpations, I'm going to now go to maybe 2 to 5 pounds of pressure. How do I decide? It depends on the size of the patient's muscles. You know, so if I have a patient where these feel really tight and strong, I might put a little more pressure than I do on Jenna because her musculature is more delicate. So part of that's just learning curve on that particular patient. So we've done masseter and anterior temporalis. I'm also going to want to do medial pterygoid. This is an intraoral muscle, so it's actually kind of hard to capture on video, but what you're basically doing is you're palpating the muscle that's behind where you go with your needle when you do an inferior alveolar injection. So you actually stay anterior to this muscle when you isolate that for that injection anatomically. But I'm going to try my best to show you. So I'm going to have Jenna open as wide as she can, comfortably, and turn your head toward me. Okay? And then I'm going to put my finger way back here, and I'm going to palpate. Is that one tender to you?
No.
No. Okay. And then we would just do the same thing on the other side. So as a basic muscle exam and screening, I always do masseter, anterior temporalis, medial pterygoid. And then, of course, if you have an interest in doing more advanced occlusal muscle diagnosis, there are other muscles, head and neck muscles, that you can look for. But in a general practice, these 3 muscles typically are going to give you the information that you need. Now we're going to move into looking actually at the tops of the teeth and what do we see even from a standpoint of soft tissues. So Jenna, one more time I'm going to have you open for me as comfortably as you can. And one of the very first things that I notice is Jenna has what we call scalloped tongue. So when I look down at her tongue, the sides of your tongue, Jenna, look like a fancy pie crust. So like at Thanksgiving when you have an apple pie and the crust is all fancy. And that really is 100% consistent with somebody who grinds or clenches their teeth. So I've already got some indication that you do clench your teeth, which you told me. Many patients aren't aware of the fact that they parafunction. So that would be information that we would give them. I will tell you, for me, for a patient who doesn't believe they parafunction, I always propose that as something they might possibly do. And I ask them about that, or I tell them that I see some evidence when I look at their soft tissues or their teeth that suggests that, versus saying definitively you do this. So I want to allow them to kind of come to that awareness. All right, Jen, I'm going to have you open again for me as comfortably as you can. And now I'm looking at the teeth, and I'm specifically looking for Do I see wear facets? So do I notice that Jenna has wear on her teeth that I think is from attrition or grinding or clenching, which means that she'd have a matching facet top and bottom tooth, and that they're flat. The enamel and the dentin are worn evenly. It does have a different presentation than erosion does. I'm also looking in there to see, does she have any cracks or fractures? Is she missing any cusps? Does she have missing pieces of tooth structure on a marginal ridge? Or she just has those classic cracks that go over a mesial or distal marginal ridge or down a buccal groove, indicative of putting too much pressure on her teeth. I can also look at things like fremitus. Fremitus is when you put your fingernails on the teeth and you have the patient tap for me, tapping up and down a couple times, and the teeth vibrate. Or you can actually ask the patient to power wiggle, okay, and see if those teeth will vibrate. By the way, if you ask a patient to power wiggle and they look at you like they don't know what to do, they don't do that parafunctional habit, so you can pretty much just keep moving, okay? I can also look at these teeth for non-carious cervical lesions or something going on sort of at the root where the enamel and the root start on the teeth, which in Jenna's case, she doesn't. Now, pretty classically, when you have a patient that clenches, which is what Jenna believes she does, you may see cracks or fractures, but you're probably not going to see true wear facets, but you will see that classic scalloped tongue. That's different than a patient that grinds, where you're going to see very clear wear facets from attrition. So we're going to put all of this information together now as part of, we've already done our assessment, our risk assessment, and we said Jenna wasn't a low-risk patient having a low-risk procedure, so she's moderate or high risk, and now I've got more information. Or I would gather this level of information from a standpoint that Jenna already had a procedure. She's come back in with some signs or symptoms of jams, and we want to move into really efficiently helping her get better. Now, there's lots of different places that you can go to learn very specifically at a much more detailed level how to do a joint, muscle, and functional or occlusal exam so that you can get really feeling very, very comfortable with how to gather that information. What we wanted to do today is just give you some basics you can do in your practice starting the very next time that you have a patient that has either a moderate or high risk assessment or is already having some post-op symptoms.